So like Lakia said, we will have sections throughout the presentation where you can ask us questions, leave messages in the chat box. We'd love to answer your questions, but we also want to remind everyone that we are just asking general knowledge questions tonight. If you have specific questions related to your medical history, we encourage you to make sure you take this information that you learned to your medical provider and ask them those specific questions. So just to tell you a little bit about our project, really quickly, I work at Georgia State University at the Georgia Health Policy Center, and we work on a project that focuses on reducing complications from blood transfusions for sickle cell disease and thalassemia patients. And we work very closely with the Centers of Disease Control to support those efforts in the community. So we are going to kick off this series and our conversations tonight around blood transfusions and sickle cell disease, how, why, and when. And we saw a lot of you all had questions about the specifics, like what are blood transfusions? Are they necessary? Why do some people have more transfusions than others? We saw those questions in your registration, and we're going to cover some of those tonight. So again, some of our learning objectives are what does blood do in the body? What's its purpose? What are blood transfusions? What's the difference between acute and chronic transfusions? And what are some reasons for having transfusions? Throughout the presentation, you will see a nice maroon-colored star beside keywords that are really important. And we're asking you all if you would just jot them down, or these slides will be made available online. So pay close attention to these words, because they're things that you may hear your medical providers say, you may hear it throughout the series, and we want to make sure that those are key takeaway and messages that you have. So before we get started, we wanted to just ask you all two really quick polling questions, and I'm going to pull those up on your screen. You should be able to, in a moment here, see two questions pop up on your screen on the right-hand side. We're giving everyone a minute to respond, so please, if you're close to your computer, just get ready to answer these questions for us. For those who are on the phone and you don't have your screen open, just to let you know what that question is, the question is, I know the reasons for getting a blood transfusion. So I know you can't respond online, but just think about whether or not you feel comfortable around that information, around the reasons for getting a blood transfusion. So quite a few people have responded, and it looks like we have somewhere right in the middle. We have some people who feel really confident, yes, I know the reason for a blood transfusion, and some folks who they think they know but may not be necessarily sure. And that's okay, because we're going to cover that information today.
Hey, you want to listen?
We have one more question, just to get everybody thinking and going on these different questions and different topics that we'll cover today. So one more question we'll be pulling up in a second here. And you again have another minute to respond to this. The question is, for the folks who are just on the phone, how confident would you feel answering the question, what is a blood transfusion? Would you feel confident, somewhat confident, or not really confident? All right, our answers are coming in. Thank you so much for responding, y'all. And again, we have about 50-50. We have some folks who feel very confident, some folks not so much. And again, that's okay. We're going to talk about all these different topics today. Dr. Jim Ekman will lead us through a conversation on blood transfusions, how, when, and why. And Lakia, I'm going to pass the presentation to you so that Dr. Ekman can guide the slides. Thank you all for responding.
Dr. Ekman, you now have control of the screen. I love that backdrop. There we are. I don't have your audio, Dr. Ekman. Hold on one moment. Give me one moment. All right, Dr. Ekman.
Can you hear me now?
Yes, we can.
Okay, excellent. Okay, yeah, there. Can you see my pointer? Is that working?
Yes, it's working.
Excellent. Okay, well, thank you very much for the opportunity to be here this evening and talk to you about blood transfusions. And I'm glad this is leading off this semester's educational activity, because transfusions in sickle cell disease are really the single most effective treatment we have. We get all excited about transplant and some of the medications like hydroxyurea, but really when things get tough in sickle cell disease, blood transfusion is something we can always count on to have an effect on the disease and really improve things. Saying that, it's really important that you understand when and how and why we give transfusions, and also understand that you as a patient or as a caregiver for a patient with sickle cell disease, an individual with sickle cell disease, really needs to know a lot about transfusions, because participating in the transfusions very actively is important to have a good outcome. And over the next three presentations, we'll go into that in some detail. Let me see. Okay, this is a very, very basic indication. Can you see my slides? Because I don't see mine advancing.
Dr. Ekman, I don't see your slides advancing.
Okay, I don't think I'm in control. I'm sorry.
I see your screen, Dr. Ekman. I just don't see the slides advancing.
Just the first one? How about now?
It's just yes, now, yes.
Okay, very good. Okay, we're set. Okay, so this is a very basic slide that tells you what blood does in the body. And blood travels throughout the body in the circulation system, and you can kind of think about that as the plumbing for the body. And you have arteries that pump blood away from the heart out into the tissues, into very fine blood vessels called capillaries. In this area, the blood does its thing. It gives up its oxygen and it gives its nutrients to the tissues, sugars and fats and things that the body needs for energy and to run. The blood then goes back to the heart and it's pumped into the lungs. And in the lungs, the blood gives up its oxygen, gives up its carbon dioxide and picks up oxygen. And this is a closed circuit, and the blood is constantly circulating through the body. This is a delivery system, and I like to think of the blood as the river of life, because the blood is absolutely the most important element in the body to keep us healthy, because it really provides all of the nutrition, the oxygen, and everything the body needs. And it also takes all of the wastes that accumulate in the body and removes them from the tissue so they can be delivered back to the places like the liver and the kidney, where they can be gotten rid of and detoxified. And so it's circulating through the body is really the reason that we can live. Now, the blood itself is complicated. It's complex. There are really three very important components to the blood. Actually, probably we should talk about four. The main part of the blood is called the plasma, and it's a fluid. It's kind of like water. It's got a few other things in it, but it's mainly water. There are white blood cells and red blood cells, and little teeny cells called platelets. The important cells that we're going to talk about for the lecture tonight, or the talks tonight, is the red blood cells. And the main thing the red blood cells do is they carry oxygen from the lungs to the tissues of the body, and then they carry carbon dioxide from the tissues back to the lungs, and that's their primary utility in the body. White blood cells are very important because they fight infections, and they fight other things that shouldn't be in the body, like cancer and other diseases like parasites. And they can be sort of thought about like the Marines. When something goes wrong in the body, there's an infection, they go out into the tissue from the blood and they fight that infection. We have platelets in the blood, and they're there to prevent us from bleeding. Whenever one of the pipes breaks, there's a little disruption in one of the blood vessels, and we start bleeding. The platelets are sort of the first line of defense, and they plug the holes in the blood vessels, and they start the blood clotting so that the bleeding is stopped and we don't lose all of our blood through the vessel that's been damaged. And then finally, the plasma is the liquid part of the blood, and it carries all of the nutrients, antibodies, hormones, and water throughout the body. And it also is very important because it controls our temperature, and it is very necessary for taking the heat that's generated in the core in the body and getting it to the skin and to the lungs so the heat can be expelled so we don't have a fever. And so those are the main components. And in sickle cell disease, the cells that we really are talking about being critically important are the red blood cells. And the red blood cells are filled with hemoglobin, and this is a protein that makes the blood red, and it's the one that's responsible for carrying oxygen from the lungs to the tissues and carbon dioxide from the tissues back to the lungs. And so the hemoglobin inside the red cells really is important for that. Now, this is a little more detailed picture of what happens as the red cell does its function in the body. And on the top here, whoops, it didn't advance. Okay, here we go. As you can see here, the red blood cells flow through the blood vessels, and they squeeze out into the capillaries, and they become very elongated. And in their normal state, they look kind of like a donut, where there isn't quite the hole in the middle. And this gives them flexibility so they can squeeze out into these very small blood vessels, and that allows for oxygen and carbon dioxide to go back and forth very effectively, and lets the hemoglobin do its job in bringing oxygen to the tissues and getting rid of the carbon dioxide. Now, in sickle cell, the main problem is with the hemoglobin, and as you all know, when the sickle blood gives up its oxygen, the hemoglobin forms genes inside of the blood cell that causes them to get all bent out of shape, and this causes them to plug up the blood vessels. And I think the best way to think about this is to think about the connector in Atlanta or a main freeway and an off-ramp where the traffic goes from the major arterial or artery off into one of the side streets. And in sickle cell disease, when this occurs, at these little side streets, the cells tend to get stuck and they pile up. And just like if there's an accident on one of the exits on the freeway, the cars get all backed up behind the accident, and that spills back into the big arterial highway, and the traffic flow is stopped, and in the body, the blood flow is stopped. And so once sickling starts, the blood vessels get plugged up, and that stops all of the blood flow, and therefore the tissues can't get their oxygen and they can't get their blood supply. And that really is the basic problem that causes the difficulties in sickle cell disease. Are there any questions about that? I was relatively simple about it, but it's a very complicated problem. Does anybody have any questions at this point?
Dr. Ekman, there is one question from the chat box.
Okay.
So someone had the question for the first slide with the image of the lungs. This person wanted to know if that image represented the left and the right sides of the body.
No, the heart is divided into the left and the right, and those are separated. And all of the other connections in the body, it's all like one big unit, so that they're not separated left and right. The left side of the heart really takes care of the blood that has lots of oxygen in it, and it pumps them. And the heart on the right side takes back the blood from the tissues that doesn't have oxygen in it and pumps it out into the lungs. And so the heart is left and right side, but all of the other blood vessels sort of go equally to both sides of the body. It's not quite as simple as that, but it's pretty much that way. Did that help, or did that make more confusion?
Let's see if Alexis, did that help answer your question? She said, yes, it helped. Okay. And thank you.
Anything else? Should we go on?
I think we're fine going on, yes.
Okay, so why would you need transfusions in sickle cell disease? Well, the first reason is that you have anemia if you have sickle cell. And why do you have anemia? Anemia is having too few red cells and too little hemoglobin. And the reason you have anemia in sickle cell disease is the red blood cells don't last very long in the body in sickle cell disease. Normally, red blood cells last about 120 days or 4 months in the body. But in sickle cell disease, the red blood cells break down very rapidly, so that they only last about 15 to 20 days, or 2 to 3 weeks. And so every day, somebody that has sickle cell anemia has to make a lot of red blood cells, many, many more red cells than an individual does who doesn't have sickle cell disease. And the body does a pretty good job of keeping up with this, but it can't do enough to keep the hemoglobin level normal. There are lots of reasons why with sickness, like a viral infection or a cold, the hemoglobin can fall even further. And when the hemoglobin level gets too low, there's not enough oxygen carried from the lungs to the tissues, and the tissues start having problems because they don't have enough oxygen. And so one of the main reasons in sickle cell disease you might need a transfusion is just to increase the hemoglobin level. This is also something that's common with anybody really that gets a transfusion, and the most common reason we transfuse anybody is that the hemoglobin gets too low and they develop anemia. And so that's really the same in all individuals who have any illness where the hemoglobin gets low. Now, there's a very special thing that the blood transfusion does in sickle cell disease. It's really, really special for sickle cell alone. And the other thing that happens in sickle cell is when you get normal red cells that have normal hemoglobin in them, those red cells dilute out these cells that have sickle hemoglobin in them. And this helps increase the blood flow and makes the blood more fluid so it can squeeze through those blood vessels better. It doesn't get into traffic jams at where small blood vessels branch off, and it flows much better. And so this is very helpful in actually restarting the flow to the areas of the body that aren't getting it, and that helps increase the oxygen out there too. So you both increase the amount of hemoglobin that's in the blood, and you make it flow better when you do a transfusion in sickle cell disease. And so that's unique to sickle cell, and why the transfusions are so important when somebody gets sick with a complication. Well, what is a blood transfusion? Well, actually, it's a very complicated process, and I want you to understand it because it really speaks not only to how important donating blood is, but also how carefully the blood is screened and how many steps are taken to make sure that the blood is as safe as it possibly can be for you. And basically, getting blood starts with somebody giving you blood. And this is done where somebody goes to a donor place, someplace like the American Red Cross or Life South, where they are good citizens and they voluntarily go in and say they want to give blood so somebody can be benefited by their blood. And so they are recruited, they go in, and the first thing that happens is that they get this long list of questions. And the screening that's done just by talking to them includes questions about whether they've had any infections, whether they've had sex with prostitutes or men having sex with other men. They talk about whether you've had a recent visit to a country where infections like malaria and Ebola virus and some other things are common. And so they take a very careful history. They take the donor's temperature and they make sure that their hemoglobin is high enough so that the blood will be beneficial. And all of that is done before the blood is collected. Once it's collected, then it's transported into the blood bank lab where again it's tested, and they do a whole series of tests on the blood to make sure that there are no infections in the blood. This screening is very, very thorough and really makes the chances of getting infections from blood very, very low. The second thing they do is they type the blood, and the reason that they type the blood is to determine your blood type, what antigens you have on the red cell, and we'll talk about that later. But basically what your major blood type is, ABO blood type, and also what your RH type is. Then if a person if the blood bank gets a request for blood, they begin a process to match it with a patient. And the first thing they do is they type the patient to make sure that their red blood cells and the donor's red blood cells match so that the transfusion will be safe. They also test the patient for antibodies, and we'll be talking about that in the second lecture. That's done to make sure that there are not going to be any reactions when the blood is given related to antibodies that would attack the transfused cells. The final thing they do before they give the unit is they take the donor's red blood cells and they mix it with the plasma from the patient who's going to get the transfusion to make sure that there's no reactions that occur between those, so that they know that's the final check to make sure it's safe to give the blood cells. Then the unit of blood is carried to the bedside. The nurses again carefully check the identity of the patient and the identity on the transfused unit to make sure that it matches that individual perfectly. And then the bag of blood is hung and it's dripped in, usually over 2 to 3 hours. And so this is really what's involved with getting a blood transfusion. You need a donor who is volunteering to give the blood. You need a blood bank that carefully tests the blood to make sure there's no infections in it, and also to make sure that it perfectly matches you. And then they go to the unit is taken to the bedside where it's given once it's determined to be safe. And they're going to ask and check your identity very carefully so that they make sure they're giving you the bag of blood that is perfectly compatible with you, and there'll be no problems from that. And so that's what a transfusion is. Well, how do we give them bloods? And this is a little bit more complicated. In a simple transfusion, a unit of blood is just hung, and it's dripped into a vein, and the blood is added to the blood that's already there. And for almost everybody that's transfused, this is the most common way that they're transfused. In sickle cell disease, we do something that's in addition to this, that's called an exchange transfusion. And what an exchange transfusion does is it gives the individual new blood, but at the same time, some of their red cells are drained out. And this can be either done manually by starting another IV in the other side of the other arm and dripping out blood at the same rate that it's going in, and that's called a manual exchange transfusion. The other way it's done is in a very special machine called a erythrocytophoresis machine. And what this machine does is it takes the blood out, it spins it in a very special bowl so that the red blood cells are separated from the plasma and the platelets and the white blood cells, and the machine discards the red blood cells from the individual who's being transfused, and the new red cells are dripped in and mixed with the plasma and red cells and go back into the patient. And this is different from a simple transfusion in two ways. One is you get everything back except your red cells, and the second is that you take out the same number of red cells as you're giving back in the transfusion. And so this dilutes out the sickle cells much more rapidly, and it gives that second benefit I was talking about on an earlier slide. And so you'll hear about erythrocytophoresis because this is commonly done in sickle cell disease when somebody's really, really sick and their sickle hemoglobin has to be gotten down very quickly and normal hemoglobin increased. Now, simple transfusions have their advantages is that it's much easier to get that done, and so you can get the transfusion to you much faster. And so if your blood hemoglobin is very low, usually we would just do a simple transfusion because we can get the blood to you very rapidly. It's less expensive because you don't need that very expensive fancy machine or somebody standing by the bedside for hours doing a manual exchange. You aren't exposed to as much blood from other individuals when this is done. With erythrocytophoresis or a manual exchange, you're pulling out some of the transfused cells as you're giving new cells. So it actually takes more units of blood, and that means you get exposed to more different people. And then the simple transfusion doesn't require any fancy equipment. It can be done anywhere very easily. Now, the exchange transfusion does have its advantages. one of the things that's really important that we use it for all of the time is in an emergency, it can get the hemoglobin S red cells down much faster than a simple transfusion can. And so when somebody gets very ill with a complication from sickle cell, we'll commonly do an exchange transfusion just so we can get rid of all of the sickle-containing red cells and give back red cells that contain normal hemoglobin and get them better faster. The other thing that's very important is that because you're taking out the same number of red cells you're giving back, you don't get as much iron loading in your body. And on the third evening, we're going to talk about iron overload and why this is very important. Now, when do we give you transfusions? Well, we give you transfusions when there's a problem. And that problem can be an emergency or an acute complication, and then it's not planned for. So you may go into the hospital with a cold or a pain crisis, and your hemoglobin gets too low, and you start getting symptoms from low hemoglobin. Then an acute transfusion would be given, and it would probably be a simple transfusion. If you got very, very ill, they might do an exchange transfusion, but they'd only do it once, and it wouldn't be planned. It would be done in an emergency situation. We also sometimes do regularly planned transfusions over a long period of time. And there are excellent studies that show if a young child has had a stroke with sickle cell disease, if you do nothing, they have a very high probability of having another stroke. So we give them regular monthly transfusions, and that has been shown to reduce the risk of stroke very dramatically. And so in this setting, you'd have a chronic transfusion that would be regularly scheduled, and this would go on really for the rest of the individual's life. Once it's started, it really has to be continued to prevent a stroke. Sometimes we do planned transfusions, but only once or for a short period of time, and these are called intermittent transfusions. And there are really two good examples of this. We know if somebody goes to surgery with sickle cell, their chances of having complications from sickle cell are rather high, about 30%. If you transfuse them up to a hemoglobin of 10, you can prevent them from having some of those complications. They do much better after surgery. And so this is a place where there would be a planned transfusion, but it would only be done once. It's also being found that when a woman is pregnant who has sickle cell disease, and they start having complications from the sickle cell during the pregnancy, the best thing we can do for them is to put them on a regular schedule of monthly transfusions, and we'll do that for the rest of the pregnancy. But once they deliver, things will go back to the way they were before they were pregnant, and those transfusions can be safely stopped. So they're planned, but only for the duration of the pregnancy or for a short time. So these are basically the three wins of when you'd want a transfusion: during acute problems, chronically where they really have to be given regularly for the rest of your life, or just a short period of time, and then you can go back to your normal state of health with your sickle cell and not have to have transfusions. Are there any questions? We covered a lot of different things there. Does anybody have any questions at this point for me? Things that I didn't make clear.
So Dr. Ekman, we have a few more questions in the chat box, and
Okay.
I am going to encourage Monica, if you don't mind, to unmute your line, just in case I don't get this question right. But Monica's question is, how do you know what is a good hemoglobin for someone with beta thalassemia? So, Monica, I see you've unmuted your line, so maybe if you could give a little clarification, too.
Well, I've heard different numbers, and I've heard some people say when their hemoglobin is 11 or 12 is good, and I've heard some people say 6. I'm not for sure what my number is.
Okay, so I'll answer that question in two ways. One is you probably should always know your number so that the doctors will know if it's changed. But in saying that, there is no number that is appropriate as a target. The reason that one would want to worry about a hemoglobin level and that somebody might need a transfusion isn't based on what the number is. It's really based on whether they're having symptoms from their hemoglobin being that low. Does that make sense? So I had patients that I followed for 20, 30 years who never had a hemoglobin level that was higher than 6.
Wow.
And so that level was perfectly appropriate for them. They didn't have any symptoms from that. They did fine with that low hemoglobin level, and they could do all of the things they wanted to do without any problems. I had other patients who had SS hemoglobin, but they had hemoglobin levels of 12 all of the time. And
Okay.
those individuals were also without symptoms, and so that hemoglobin was perfectly normal for them. The reason you need to know the number, though, is if your hemoglobin level is normally 9 or 10, and you come in with a complication and it's 6 or 7, then that is a problem, and that has to be at least watched very carefully so that you don't get into problems with the low hemoglobin. And that includes being, asking all of the time and testing to make sure that the pulse isn't too fast, they're not breathing too quickly, or they're not short of breath where they would need a transfusion, not because of the level, but because the hemoglobin level has changed over a very short period of time. Does that make sense?
Yes, that makes sense. I understand. Thank you.
Yep.
Before we
you
get
so
into the next question, I just want to remind everyone, so just now I unmuted Monica's line. I have muted everyone's line on this end to cut back on background noise. But when we get into questions, it's best to type it in the chat, but I can also unmute briefly so you'll get an opportunity to comment. It is, however, best to type it into the chat.
Okay. I have several more questions here, Dr. Ekman, so just to be mindful of time, we'll just kind of go through these quickly. So Lisa had a question about clarification on when the donor blood, she asked, do they check the donor blood with the patient's plasma in the blood bank or with the nurse? So when is the patient's blood checked? Or when is the donor blood checked for the patient's plasma?
The cross match is done in the blood bank. So that test is done in the blood bank. The only thing that the nurses test is that she looks at the information that's on the bag of blood and matches that to the patient's wristband that's on their arm to make sure that they're giving the unit to the right person. That's the only testing she does. And then she will also do vital signs, take your temperature, your blood pressure, and your pulse while you're getting the blood transfusion to make sure you're not having any kind of reactions to the blood. But she doesn't do anything in terms of testing the blood.
Okay. And Lisa, just let us know in the chat box if you have any follow-up questions. Lisa had a second question asking, is there indication for a manual transfusion besides the younger toddlers that can't handle the machine? So I think Lisa's asking about manual transfusions and whether or not.
So
I'm not sure.
Yeah, I think I can explain that. So manual transfusions are basically done when you don't have a machine available. And so if you're working in a hospital in this country that doesn't have that very expensive machine in the blood bank, then you have to do it manually. In many parts of the world, in Europe And in Africa and South America, they don't have many erythrocytophoresis machines, so they do almost all of their transfusions manually. So that's the main reason you would use a manual transfusion, because you didn't have the machine available.
Okay, and the last question for this segment, and we will make sure to respond to all questions, you guys, but Melinda would like to know, is it recommended to have preventative transfusions, such as before a long flight or other instances of travel?
The general answer to that is that individuals should not need a transfusion before they take a plane flight. That's almost never necessary. Now, the only thing I would say is, remember what Ashley said at the beginning, that I can't give medical advice, and so that is something that you should discuss with your doctor, and you might have some special situations where they would want you to get transfused before a plane flight. But as a generalization, that isn't done. I never had to give a patient a transfusion just so they could go on an airplane flight.
Okay. Okay, thank you, Dr. Ekman. There are a few more questions, but we can continue with the presentation and get to these questions at the next segment.
Okay, very good. Okay, so when you get transfusions, what are the complications that we need to have you get transfused for? Well, there are some things that really almost always individuals get transfused for. And we already talked about this a little bit. And first is acute stroke. And we know that if somebody has a stroke, that they're at high risk. About 75% of the time, if nothing more is done, they'll have another stroke. And if they're put on a regular program of monthly transfusions, that risk can get down to 5 or 10%. So there's a really dramatic reduction in the chances of people having recurrent strokes if they get regular transfusions on a chronic basis. Now, the other thing that they found is that you can screen young children to see if they're at risk for a stroke, and they do an ultrasound to look for high blood flow, and that's called a transcranial Doppler. And it's been shown that if that's abnormal, that also puts the child at very high risk for a stroke. And if you put them on transfusions on a regular basis, you can prevent that first stroke from happening. And so those are two situations where individuals almost always are put on chronic transfusions. The other thing that can happen is as individuals get older or they develop kidney or heart disease, their body just can't keep up to make enough red blood cells, and their hemoglobin is so low that they're symptomatic all of the time. And then those individuals would need to be on a chronic transfusion program on a regular basis just to keep their hemoglobin high enough so that they wouldn't have symptoms from the low hemoglobin. And that also occurs not commonly, but with some frequency in individuals when they get into their 60s and 70s, where they get complications other than the sickle cell that require them to have a higher hemoglobin to keep them from having symptoms. Now, there are other situations where we'll do chronic transfusions, but we only do them for a short period of time. And the reason we don't do them forever, I'll talk about on the second evening on Wednesday. But very often when I had a patient who was having very frequent pain crises and it was really interfering with their lives, they weren't able to take care of their families, they couldn't complete their schoolwork, they couldn't hold a job, we would put them on transfusions for 4 to 6 months to see if that really would stop the pain crises from happening and would prevent them from having such frequent pain crises that it would disrupt their life. And then after 6 months, we'd sit down and we'd talk about it because there's a lot of a lot of effort involved in getting a monthly transfusion, and so we discuss it to decide whether they wanted to continue that. When individuals have really repeated serious acute chest syndrome, where this is a very serious lung complication, very often we'll put the person on transfusions for 4 to 6 months and see if we can quiet things down. With pregnancy, we talked about already during the pregnancy, some women, not all women, but some women really do better if they're put on transfusions on a regular basis through the pregnancy. And then if somebody develops heart failure or kidney failure or low oxygen from lung disease, then sometimes they need to go on transfusions until those can be improved. And once they're improved, they're treated. Very often the transfusions can be stopped or at least spread out so they don't get them as regularly. And then finally, sometimes individuals have abnormal blood vessels that form in the brain and they're put on chronic transfusions, usually just until they have some surgery to correct that, but so they're only on them for about 4 to 6 months or something like that. Now, there are a lot of times that individuals get intermittent transfusions, and these can be done if the hemoglobin level gets too low and the person has symptoms. So I told you already, there's no magic number that we have to give blood for, but when it causes symptoms and the hemoglobin is low, shortness of breath, real fatigue and weakness, the heart racing with minimal exertion, then probably a few units of blood will help the situation, and those are given once and probably not repeated unless the symptoms come back again. With acute chest syndrome, with acute kidney failure, and with acute bone marrow failure, where the bone marrow stops making red blood cells, we often give red cells for a few days or weeks and then stop them again. And then I already said that before surgery, we want the hemoglobin level to be 10 before we go to surgery because that's been shown to prevent complications. And so those really are the main reasons that we don't do it. Now, there's another thing that we have to talk about, and I'll be repeating again and again. When should you not get transfused? And one of the situations where you should not be transfused automatically is because the hemoglobin is low. And some physicians and patients have magic numbers that they use, like 7 or 8 or 9 or 10. And every time the hemoglobin level gets below that, they want to give their patient a transfusion if they're a healthcare provider, or the individual gets nervous and wants a transfusion. And that really isn't necessary, and as you'll find out in the next 2 sessions, that it causes bad problems that we really want to avoid. The other situation where you do not always need to be transfused is for every pain crisis. And pain crisis is not made shorter by giving a blood transfusion. You can give regular transfusions to prevent pain crises, but there's never been any studies to show that if somebody's having a pain crisis, giving them a pint or 2 of blood or a couple units of blood will shorten that crisis. And the reason I stress this is because, unfortunately, these are the most common reasons for people to get intermittent transfusions, and they're not needed. And as we'll find out in the next 2 sessions, they can lead to some problems that really are much more significant and can be avoided by just not getting very frequent transfusions. So we have some important words to remember: hemoglobin, antigen, antibody, simple transfusion, exchange transfusion, acute transfusion, chronic transfusion, and intermittent. I introduced those to you tonight, and you'll be hearing them again and again because there's a bit of redundancy in this series, and we did that on purpose because I really want you to be experts on transfusion and sickle cell disease.
Right. So, Dr. Ekman, before we go to the polling questions, we do have a couple more questions in the last few minutes here. I'm going to kind of merge two questions. We have someone who's asked, will a chronic transfusion change a person's blood type, and the other question is, does the hemoglobin change at puberty with boys?
So the first question is excellent. No, the blood type does not change with a transfusion. In fact, the donor and the recipient have to be matched perfectly, so they're getting the same type of blood. So there's no change in the blood type with a transfusion. There can be with bone marrow transplantation, but we're not talking about that. So that's different. And the second question was an excellent one too, but the second question, Ashley?
Yes, does the hemoglobin change at puberty with boys?
Yes, absolutely. So normally a young male and female have the same hemoglobin level, about 12, and at puberty the boy's hemoglobin level goes up to about 14. And that's almost exclusively related to the fact that they start making testosterone, and the testosterone, the male hormone, causes the hemoglobin to go higher. So males do have a higher hemoglobin than females normally. This happens in sickle cell disease too, but it's usually not quite as great an increase.
Okay, great. Our last question is, how does a cold or virus impact the hemoglobin or red blood cell lifespan?
So an infection like a virus infection, a cold, doesn't usually affect the lifespan of the red blood cell. What the virus does is it slows you from making new red blood cells. So they last as long, but the hemoglobin goes down because you're not making enough to keep up. So normally you have a rate of making red cells that balances the rate at which they're being destroyed. And with the virus, you slow making new cells, so the hemoglobin goes down because you don't have enough new red blood cells. Does that make sense? Does that answer the question? So it's not reducing your hemoglobin goes down, not because the red cells don't last as long, but because the bone marrow can't make as many of them.
Okay. The person with that question said yes, it makes sense. So we are good to go there. So, Lakia, if I could just ask for your help for a second. I'm trying to pull up the poll question again, but I'm having some difficulties. And as we pull this up, if folks on the phone, if they have questions and you could not type in your question, please feel free to share your question now or ask your question now.
Ashley, you should be able to pull it up now. Let me know. Everyone, yes, in order to ask your question, verbally, I'm going to have to unmute your lines. So please, if you've just called in or called in a bit late, please select mute on your phone or mute your tablet, smartphone, or computer to cut down on background noise, and then unmute in order to ask your question.
Information too.
Okay, and again, we're just giving folks an opportunity who are just on the phone and weren't able to enter in the chat their question to ask their question.
So everyone who has called in from the phone only, you have been unmuted. You should be able to ask your question now. Everyone else, please continue to use the chat.
While we're doing that, I'm going to open the poll, and again, we're going to ask those same questions that we asked at the beginning. So you have a minute here to answer. I know the reasons for getting a blood transfusion. So if you would please just respond to that question for us. We have about another 30 seconds to respond, and it looks like quite a few people have changed their response from I'm not sure, I don't know, to yes. So that's great. Again, if you all still have questions, the chat is open. I'll make sure that my email is available also. So if you have questions, I can make sure that in the next session that we respond to those questions.
And anyone, if you feel your question was missed, please type it in again.
Yes. Okay. And then the second question I'm pulling up now. And if you would please, there'll be a minute to respond to this question. And the question is, again, how confident will you feel answering the question, what is a blood transfusion? And while you guys are answering that, I want to say thank you again for joining us tonight and for listening in. I definitely appreciate it and know it's been a long day, so your participation is just so much appreciated. We have a few more seconds, but it looks like everyone has responded. And most folks feel confident. There are some people who are still somewhat confident in answering that question, and that's okay. We will have continued series and continued sessions to talk a little bit more about blood transfusion. So make sure you come back to the rest of the sessions to hear and learn more. So, Lakia, from here, I'm going to pass the presentation over to you if you want to close us out.
Fantastic. Thank you all very, very much. Thank you, Dr. Ekman, for that fantastic presentation. Thank you, Ashley. We're very excited that you all chose Warrior University as a platform to provide this very informative information. If you came in a bit late and you missed it, at the end of the series, the presentation will be made available online. You'll be able to find it at sicklecellconsortium.org/Warrior University, and it will be archived as we move into the next series. We do have several series upcoming, including a series on FDA and patient engagement and how we can work directly with them, and a series that will focus on teaching the NHLBI guidelines for sickle cell treatment and care in the hospital. We're really excited about all of those. If you have any last-minute questions, go ahead and type that in. You can reach Ashley Singleton. You all that register, you'll see her information in your email. Next session is actually Wednesday, February 27th at 6:30. These classes will continue Monday and Wednesday as we work through the series. The next one is on keeping it safe, blood matching. During that series, hold on one second, I will. If you're getting a bit of background, everyone please just mute your line if you're no longer asking questions. That series, the next class on Wednesday, will focus on learning how to keep detailed records of your transfusion history, comprehending potential hazards and benefits, and how to prevent and treat medical issues related to blood transfusion. You'll be able to describe your role in preventing blood transfusion complications and understand why you need to follow instructions for treating these complications. I think this is an incredibly important one. We will then later on for session 3 get into specifically iron overload. This next one will provide more general information on records and blood matching. I know I personally choose not to transfuse a number because my baseline hemoglobin is quite low. So instead, I transfuse symptoms, just as Dr. Ekman taught. And I think it's incredibly important that we learn this information so that we can become expert patients. Looking forward to our next class, again, Wednesday, 6:30 p.m. Thank you very, very much, Ashley and Dr. Ekman. This was a fantastic session. Thanks, everyone.
Thank you.
Thank you, Lakia. And Emilia, I do see that you asked a question. Dr. Ekman, I don't know if you have a second to hold on and listen in, or if you'd rather just respond offline, maybe in an email. I'm not sure how you want to handle that.
I'll be happy to try to answer it.
Okay. Thank you for all those who did join in. And Amelia, I want to make sure we respond to your question. Amelia would like to know, why does a blood transfusion not help with a pain crisis? A crisis.
Good question.
That's a very good question, and the only honest answer I can give you is we don't know for sure. I think what happens is that when you have a pain crisis, it starts out with the kind of simple sickling that I showed you at the beginning, where blood vessels get blocked up, but it rapidly becomes much more complicated, and the transfusion doesn't prevent the pain and suffering that occurs in response to all of the damage that's done while the blood flow isn't getting to the tissues. And so that's the main reason. And so the pain is actually probably the worst when the blood flow is actually getting better again on its own. And that's really not a very satisfactory answer, but because we really don't understand. We do know that if you give regular transfusions on a monthly basis, the number of transfusions you'll have will go down. And if you get a transfusion during a hospitalization for a pain crisis, you're less likely to have another pain crisis in 1 to 2 weeks, but it doesn't actually shorten the one that you're having right at this moment. And that's probably because by the time there's really a good onset of pain, the damage has been done, and the body is no longer just sickling, but in the healing process. Does that make any sense? I know it's complicated because we really don't understand it.
So Amelia hasn't responded to say if that made sense or helped or not, but Amelia, if you do have follow-up questions, okay, she said yes. It does confirm her understanding, yes.
Okay.
She gets it.
Excellent,
okay.
Thank you.
All right, well, thank you all so much.
Thank you, everyone. If you found this valuable or useful, please do feel free to share online to have others join us. It's not too late to register for the remaining 4 classes in the series. See you all Wednesday.
Yeah. Bye. See you Wednesday.
Bye. Good night.
Good night.
Good night.
Hmm.